Thank you very much, Gary, for the kind introduction. I'm very honored, actually, to hold the annual lecture of DDL. I think it's a great honor to me, and it's a great pleasure to talk about digitalization in respiratory medicine and where are we heading to. So a quick overview of my presentation. I first would like to start off, is digitalization an asset as such? So do we profit from it? What is artificial intelligence and why do I think is it sensible to use it? What are AI-driven solutions on the market? And of course, the pain and gain of digitalization. Looking at what we already have on the market. So we have electronic patient records, enabling physicians to look at the data of patients. So we will not have this polymedication in future, that different physicians prescribe medicine which is not working with each other to the same patient. We have e-learning not only for the people who work in healthcare, but also for the patients. We have digital hospitals in some countries, not so much in Germany, more in the UK, I think. And the times are over when people run from one department in the hospital to the other carrying paper, and the paper is late for the patient. We have digital monitoring, so devices which feed into the electronic patient record and feed into the digital hospitals. We have digital customer interaction, and here we have the first time not patient but customer. So the patient starts to be treated as a customer, booking appointments, having video calls, and we have the trend that we use more and more non-medical device wearables to see the status of the patients. But all those things we had before on paper. So that is nothing revolutionary. It makes our life hopefully easier, and it makes it even more cost effective, I hope. But that we did on paper. What we can do with that, because it is creating so much data, is we can use those data in artificial intelligence and do completely new things. So why do I think we need artificial intelligence? The human brain is sadly limited. There is a publication of Stead et al., and he states that the human brain can take 5 sets of factors per decision into account. I guess that's the average brain, and I think there are probably many people who can take more sets of facts per decision into account. But when we look what the genomics is producing, it's thousands of data sets. So the human brain will never be able to process that all for a decision. So why don't we use the collective power of a system of brains? Why don't we use AI for that? And that's what I'm proposing and what I'm showing today. Looking at that is, what is data? We need, for artificial intelligence, data is key, and the more, the better. So we have the obvious data. We have pulse rate, we have heart rate, we have breath rate, and that shows us the status of the patient. And then we could take into account the mood of the patient, the weather, the pollen, is the patient moving or not? That could tell us also a lot about the patient and could predict a lot. There are even people who are trying to correlate how people's smartphones are charged on average, and if that correlates to healthcare. Maybe we laugh about that in a couple of years because it was a nice try, but maybe it turns out that people who charge their smartphones regularly also take better care of their healthcare. Who knows? And just to lay the grounds, I would like to say only a few words about artificial intelligence. So artificial intelligence is anything which mimics human intelligence, and the emphasis is on mimics. It is not really intelligent, it just mimics it. And there we have machine learning and deep learning. And both of them are part of artificial intelligence. I'm emphasizing that because very often in the literature, you see artificial intelligence and machine learning and deep learning. So it's both artificial intelligence. And what is the difference? The difference between the two is that for machine learning, you would like the machine to know or to distinguish between objects, cars. So by machine learning, the human will extract the features. So the human will tell the machine, those are cars, and they usually have four wheels, they have a windscreen, they have doors, and extracts the features. And then you give loads of pictures of cars to the machine with these features, and in the end, it can distinguish between other objects and cars. For deep learning, you don't need the human anymore. You just give even more pictures to the machine, and after a while, it will be able to distinguish between other objects and those objects which have four wheels, a windscreen, and everything, and are smaller than lorries. The human has to name the car, but the machine will learn by itself the car is a car. And that makes it, I think, very obvious that especially for deep learning, we need to be very careful which data we are using to feed the machine. Otherwise, the outcome will not be very good. So just a couple of examples, because I think it is very exciting what we have already on the market and what is already possible on the market. And the first few examples in the diagnosis of respiratory diseases. So I guess that the best known example is the Spirometry. There is a company called Nuvo Air, and they are looking at the results of spirometry curves, and the AI is distinguishing the pattern, so restriction and obstruction, and it diagnoses the disease. And they have done a clinical trial and have included 50 different spirometry curves and have asked 120 pulmonologists in 16 countries to distinguish the pattern and make a diagnosis. And probably not surprisingly, the pattern, the machine was 100% right, because what AI is doing best is pattern recognition. So that's what AI is made for. And the physicians were actually not quite as good. And it's, I think, more prominent and in the diagnosis. Again, the machine was at 82-85%, but the physicians were at 45% doing the right diagnosis. And there were 88 senior physicians in this trial. So we always knew it's not so easy to have only the pattern of spirometry and make a diagnosis. Physicians use, of course, more than only this curve. But this makes it obvious that AI could help doing the right diagnosis. So another example is more general, but of course also works for respiratory patients. We have symptom checkers. And the most prominent one, at least as far as I know, in the UK and Europe, is ADA and Babylon. So those ask several questions to the patient. They ask about medical history, risk factors, and acute symptoms. And with that, they try to find a plausible cause for the acute symptoms. They are not quite as good as GPs, as it turned out in a clinical trial, but their risk is rather low. So in terms of safety, they are very good. The advice they are giving is very good, and it's not a safety risk. They're just not always on spot with a diagnosis. But one of the German doctors, Mr. Kuhn, has written in a German doctor's journal that it's probably better that a physician on night duty after 6 p.m., which I thought was funny. And the third and last example is cough detection. Especially with COVID, we had quite a few companies trying to detect cough and distinguish some diagnosis from the cough. And there's a Swiss company I would like to mention, Resmonix. They have done quite a few clinical trials. And in one clinical trial, they could correlate nocturnal cough and sleep quality to predict asthma. They had a sensitivity of 75%, and predicted asthma attacks 5 days before with that sensitivity, which I think is quite impressive. So you put the smartphone next to the bed at night, and it recognizes cough and tells you how well your asthma is controlled, which I think could be one diagnosis for the future for patients who do not like to do peak flow. My next few examples are from therapy. So this is our own. This is QATAR. We have developed QATAR to support respiratory patients in their everyday life. So QATAR has everything from diaries to symptom checkers to weather and pollen, but it has one USP. It trains the inhalation. So where we come from, as Gary mentioned, I come from drug delivery, and I was always a bit upset that we never knew which dose is reaching the lungs when patients use the inhalation device. And for that reason, we have developed an online, so it runs in an app. It's an intelligent algorithm running in an app. And it, first of all, shows the patients what they have to do in every step. So it tells them shake, exhale, inhale, and spray at the right time. It shows them in real time if they're doing that, and it gives them a sum at the end. I'm very sorry, but the new inhalation trainer I have only in German. It does exist in English, I promise, but the video I'm showing you is in German. So it tells her to shake, and you can see the little MDI popping up and down, and the particles are distributing in the canister while she's shaking. That's the response. Tells her to inhale and to puff at the right time, keep her breath, and exhale again. And in the end, you get the summary. So the shaking was quite good. She exhaled before. The inhalation was very good, and the puff was at the right time, but her breath hold was a bit short, so she only had 90%. Another example of AI in therapy comes from the pulmonary rehabilitation. So the physiotherapy, we know that this is a very important pillar in therapy for respiratory patients. And we also know that most of the countries do not have the patients nor the money to give that to their patients. So for that, I think Kaya is an excellent idea. It does physiotherapy for COPD patients. It teaches them how to breathe and how to mobilize again. And it brings physiotherapy home. So for patients who do not have the opportunity to go to a trainer. So with that examples, you can hear it. I'm very optimistic, and I'm very fond of this digitalization route. But of course, with every new development, with every new technology, you have risks and limitations. And the limitation of digitalization and AI, the machine will never have common sense. So without the human factor, without the human oversight, it will not work. And to me, the greatest thing which differs us from the machine is empathy. So I think when we are using AI, and when we are using digitalization, we will be more and more able to focus again on the empathy, on the contact to the patient, and let the boring tasks be doing by the machine. And to me, the one of the greatest risk using AI is data. It's not very charming to say, but it is never as true as here, garbage in, garbage out. If you do not look at the data you feed the machine to learn, you will not have a good algorithm. We have seen in Facebook that algorithms turned racist within an hour or two, but it is because it was fed with racist data. So everything we would like to eliminate in our healthcare or in our society, we shouldn't feed into the algorithm. Otherwise, we will have a problem with our AI. And one of the risks I also see is that technology is moving fast and big companies are moving fast, and legislation is moving much slower in regulation. So the EU was proposing this April regulations on AI. We are using that for a long time. The tech companies are using that even longer. They are using it for the last 20 years. So now are coming the rules and regulations. And that's where one risk is that people do get data who maybe shouldn't look at those data. So we have the situation, for example, in Germany, that we do not have a really good digitalization. So the physicians do not have digital standards to send data. What are they doing? They use WhatsApp to send each other patient records. And I mean, Meta is already building a lot of information from Facebook and from WhatsApp. And I think it's not very sensible to use those then to send patient records. So what I'm trying to say is we really need to take care who gets the data and who can process those data. But as you heard in the first part of my talk, I think there's loads we can gain with digitalization. And with those few slides, I would like to wrap up my talk. When we do it right and use the connection between the human and the machine, we can have superior results to either having only the human or the machine on its own. We can really move into targeted personalized medicine, a thing we are talking about for the last 20 years, and we haven't done it because we didn't have the right data to do it, but now we have it. And we can move into patient-centered medicine. So the physician and the nurses should have more time for the patient. We could have, and we will have, predictive medicine. So we will have the machine telling us several behaviors you are doing already again. Last time you had an asthma attack afterwards. Or as here in the example, the weather is not very favorable. Take your spray, maybe one more puff. So rather than only looking at the symptoms and curing the symptoms, we can look at prevention of the symptoms. And last but not least, most physicians haven't studied medicine because they wanted to be bookkeepers. The physicians want really to get back to the patient and connect to the patient and help these people. And digitalization will help us to get rid of all these boring tasks. With that, I thank you very much for your attention. I would like to give credit to We Need to Talk.ai, where I have these lovely black comics from. If you want to have a look, it's a nice book to read and easy reading. And I'm happy to answer any questions.
Sabine, thank you for that excellent presentation. Really appreciate that. Lovely way to conference. Okay, I'll hand over to my esteemed colleague, Dr. Forbes, I think, who has some questions for us. So, Ben, over to you.
Yeah, thank you. It's been really fascinating and forward-looking. So plenty for us to think about, and stimulated a number of questions. First one is, I think you've shown very well how the AI and digitalisation can inform clinical decision making, but is there also an opportunity to use the digital platforms to influence patient behaviour? In other words, to motivate the patients to do better and take more responsibility and more care of themselves?
Yes, there's this nudging we're all trying to do to the patient, and there is, I'm not sure if we would, we probably also would use AI to it, to see the patient's behavior and nudge before when we say different things. Yes, by any means. To me, a well-informed patient is easier to nudge because they know why you're trying to change their behavior and what would help them. And personalized medicine will make it easier too, because then we can tell this patient, look, your asthma always flares up when you do this. Please stop doing that. Or it would really help if you mobilized again and get moving and walking. I think when we personalize it and involve the patient more, it will for sure engage the patient better.
I have one question that came through. I think it's quite a good one. Based on some of the data you showed, I think from the Nouveau Air, Sabine, I think is one of the outcomes of that we should stop pulmonologists actually doing diagnosis, because if they're any % at the time, what's going on? So can you talk to us a little bit about that? Because I thought that was mildly alarming, that figure.
No, of course, we shouldn't stop them doing diagnosis, because they see the patient and they have more factors than only this curve. So they have a much better result when they have all the data they need. But what I think is it would help them tremendously to have AI saying, it could be this, have a look.
Okay. So it's a sort of a really important, perhaps, training feedback. Not necessarily for the senior ones, possibly, but also but the supportive evidence. Okay. I think that's important, because that data look quite striking, I think, if you like, and quite worrying until you hear that context. Thank you.
And there are a number of questions about the practicalities of how patients access the Care app, which then wraps into the sort of health economics of it all, as to who pays for that, and obviously the opportunities in that kind of space.
So the practicality is, as far as I know, the NHS has an app store where you can download medical apps from. And here in Germany, we download it from the Apple and Google App Store, but you get a code from the healthcare insurer. And in both cases, if you can show clinical evidence as for any drug, then you have a high chance of reimbursement.
Okay. One more question then. I think it's a detail, but it starts off quite nice. It says, brilliant talk, thank you so much. But then the person goes on to ask how you are able to determine the breath hold time. Is that from the video that the smartphone can see? So I guess it's a technical question.
Yeah, we use the video and the audio, so it's the absence of breath noises, which is the breath hold, and the video too. But it's more the audio. We can distinguish between inhalation and exhalation in the breath, and if we do not hear any of that signal, then it's a breath hold.
Okay, and I think in previous conferences we've heard a little bit about some of the challenges of filtering out background noise. Is that an issue? Because in perhaps the quiet, controlled environment, that's fine, but in a busy workplace or at a bus stop, does that represent more formidable challenges?
Yes, that does. That presents a lot of challenges. And basically, if the background noise is louder than your inhalation, then we will not be able to hear it. And the feedback to the patient is use your inhalation device without the app, record that you have used it, and do it when you are in a quieter. But I mean, not many people inhale on a bus. And if they use the emergency spray and they will not use an app, then.
Sure.
Another very appreciative member of the audience, great overview, but they've asked a question: how do we influence the patient from their perspective to recognise the healthcare system is supporting the patient versus Big Brother is watching the patient and feels around that kind of space?
That's a problem. And what we do see, my experience is at the moment a bit limited to Germany, but there is apps like ours, which is also promoted by some healthcare insurers, and we do not see a great feedback or a lot of patients really trying the app out then if it's by the healthcare insurer. If the physician is convinced and once a physician is prescribing it, and that's what's happening in Germany, that you can have apps on prescription, it's a different talk. So people trust their physician, they don't trust the healthcare system. And I think you will always need the physicians there.
Okay, good. Thank you, Sabine. I think in the interest of time, we'll stop there. I need you to imagine now a wave of applause from across the globe coming to you. I'm not sure how to mimic that, but I'm sure it's there. So again, thank you very much.
Thank you very much for this warm welcome. Thank you.
No problem.